Hello, my friends. Welcome to my YouTube channel. My name is Dr. Sayed Kazmi, and today I'm going to talk about pediatric migraines. For those of you who are watching my channel for the first time, a subscribe would be fantastic. And if you like my videos, do share it with your friends. And if you've got any questions or queries, put down your question and queries in the comment section below, and I will try my level best to get back to you as soon as possible. So, without further ado, let's dive straight into our today's topic, and that is pediatric migraine. Now, please keep it in mind that this is not a very exhaustive or extensive lecture. I'm just trying to focus on some of the key points in pediatric migraine and try to make it as simple as possible for you guys. Now, migraine is basically a form of primary headaches, the international classification for headache disorders, and the third edition, revised edition, which came back in 2016, classifies migraine as a part of primary headaches. And primary headaches simply mean those headaches which have got no organic reason. They are usually functional in nature. Now, back in old days, it was thought that migraines are caused by vascular disturbances, and the primary theory at that point in time was that primarily somehow the brain vasculature or the vasculature in the head and neck region, somehow what happens is that it leads to intense vasoconstriction followed by an abnormal vasodilatation, which leads to this throbbing pain in the head and neck region, which they used to call it as migraine. But our understanding of migraine has improved in the last decade, probably 10 to 15 years, and now we are in a more better position to understand what primarily happens in case of migraines. Now, the recent theory about migraines is that it is something associated with a phenomenon, a strange phenomenon, which is known as cortical spreading depression. Now, what is this cortical spreading depression? This cortical spreading depression is basically an abnormal depolarization, sustained depolarization of neurons. Now, please keep it in mind, do not equate this with a seizure, which is an abnormal excitatory firings of the different neurons and unsynchronized firing. This is more of a sustained depolarization, and sustained means that once the neurons are depolarized, they remain in the depolarized state and they're not able to repolarize, which leads to a sustained strange phenomena, which we call as migraine. So this cortical spreading depression can appear anywhere in the brain. Most of the time, it usually starts from the back of the brain, the occipital region. And then over the next 15-20 minutes, it gradually spreads. It just spreads like, if you put a drop in a pond and the wave spread, the same way this wave of abnormal depolarization spreads. So sometimes it can spread just over the cortex. Sometimes it can just go down, like from, if it's, let's say, if it can start from occipital lobe, it spreads forward and then it goes down into the deeper structures of the brain, like the hypothalamus, the midbrain, and even into the brainstem. Sometimes it can arise from somewhere around the hypothalamus or deep areas of the brain, and then it can gradually spread into the surrounding areas. So there is no special starting point. It can start from anywhere in the brain. Why it happens, we don't know so far. They say there are certain triggers which can suddenly start this abnormal sustained depolarization. That could be weather, that could be certain types of foods, that could be exercise, that could be emotional disturbances, so on and so forth. Now, to understand pediatric migraines, you also have to understand the deeper structures inside the brain. And in particularly, I want to talk about hypothalamus and the adjoining areas. The hypothalamus is one of the areas, very important areas in our brain, which controls so many of our subconscious things in the body. For example, it controls temperature, it controls your hunger, it can control your emotions, so on and so forth. So when this cortical spread of this depolarization, if it starts around the hypothalamus or if somehow reaches the hypothalamus neurons would get abnormally depolarized, and that leads to some of the phenomena that is associated with migraines. Now, migraine is not just pure headache. It is headache associated with certain autonomic characteristics. Like in pediatric age group, obviously tension headaches are more common than migraine, but migraine headaches, they've got few characteristics. Number one is that migraine headaches, they are worsened by activity, which is not the case in tension headaches. Number two is the pediatric migraines are associated with autonomic phenomena like nausea, vomiting, pallor, photophobia and phonophobia, so on and so forth. Now, majority of these associated symptoms of migraine headaches are because of the abnormal excitation or abnormal sustained depolarization of the neurons, either in the hypothalamus, either in the subthalamic area, or in the areas surrounding the hypothalamus. That includes the areas in the midbrains, in the pons, and in the medulla. So what happens, for example, if the cortical wave of depolarization starts from the occipital area, so you can get like, visual areas are actually situated in the occipital area, so that people can get zigzag lines in front of their eyes, or flashes of light, or simply the bright light doesn't look great in your eyes. We call it as photophobia. So just keep it in mind that as soon as this wave goes down into the hypothalamus, and the hypothalamus neurons, they get abnormally depolarized, sustained depolarized. It's just like, for example, if you have got music player and you increase the gain to the maximum and you sustain it. So you can just imagine, if you just increase the gain, how much noise, sound would be there in your vicinity, and how bad it would be on your eardrums. So the same happens to this autonomic switch. So it goes to the maximum volume and it stays there. So when the hypothalamus is abnormally depolarized, sustained depolarized, so you can have strange phenomena, like you can have perspiration, you can have emotional disturbances, you can have strange phenomena like cutaneous allodynia, in which you feel like your skin is very much sensitive to touch. And as the wave spreads down into the midbrain and into the brainstem, certain cranial nerve nuclei which are lying in the vicinity, they can also get excited. And in particularly, I would like to talk about the trigeminal nerve nucleus and the vagus nerve nucleus, because they play a very important role in the associated phenomena of pediatric migraines. Now what happens? Trigeminal nerve is the main sensory nerve of head and neck region. So trigeminal nerve actually supplies, it actually branches into three branches: the oculomotor branch, the ophthalmic branch, the maxillary branch, and the mandibular branch, and they bring the pain sensation from the face area. And it also supplies the dura mater. Now, dura mater is a thick covering around the brain, and it has got pain receptors in it. So if those pain receptors are stretched or are excited, that would lead to pain in your head. So somehow when this cortical spread of depolarization reaches the fifth cranial nerve nucleus, so you feel pain, because this is the pain center coming from all this head and neck region. So you will start feeling pain in the area of head and neck. So you can have pulsating pain, unilateral pain, or sometimes bilateral as well if the wave has spread to the other side as well. More so in children, which they usually in children it's not unilateral, it's mostly bilateral, because small brain and it just crosses to the other side as well. So you can have pain in the head, you can have pain behind the eyes, you can have pain in the jaw, in the face, and this is all because of fifth cranial nerve nucleus excitation, because the abnormal wave of depolarization has reached there. At the same time, if the vagus nerve is stimulated, so you would have pain in the area of the vagus nerve, and that is one of the reasons that in pediatric migraines is usually associated with abdominal pain. So kids who have got headaches, they also complain of abdominal pain, because again the cortical spread of depolarization, it goes into the areas of the vagus nerve as well, and you start feeling strange sensation, nausea, and then abdominal pain. So it is all associated with that. So please keep it in mind that the old theory of being a vascular phenomenon is now discarded, and the current theory is that it is an abnormal wave of cortical depolarization which can start in any part of the brain, more so in the occipital region. Then it spreads and can go down into the subthalamic area and into the midbrain and into the medulla, and can cause all these features. Now, coming down to the types and then the clinical features. Now, International Classification of Headache Disorders divides migraine into three types. So there is a migraine with aura, migraine without aura, and a probable migraine. So they've got very strict criteria to diagnose somebody with migraine. So migraine without aura, in which you don't have got these premonitory symptoms or flashes of light, it's just more of a headache, sustained headache in the head and neck region, sometimes associated with abdominal pain, which you call as abdominal migraine. That type of migraine, which you call as migraine without aura, for diagnosis of this type, you need to have a repeated history. So there should be at least 5 attacks, whereby the periods in between those 5 attacks should be symptom free. The pain can last anywhere between 2 hours to 72 hours, and then it should have two of the following 4 things. So it can be unilateral, it can be throbbing in nature. It's usually of moderate to severe intensity. It's not mild. It's something which is bothering you. And the thing is that it's not worsened. It's usually worsened by activity. Remember, this is one of the characteristics of migraine headaches, that they are worsened by activity. If they are not worsened and they are mild nature and sustained, even if they are sustained, they are usually classified as tension headaches. For migraines with aura, so again, you need to have at least 2 attacks in the past. The pain can be anywhere between half an hour to 72 hours. And then you can have what we call as an aura. So aura can be of different types. Aura can be like, for example, you can have sensory aura, where you have got strange sensations, deja vu phenomena. You can have visual aura, where you see zigzag lines, photophobia, or flashes of light in front of your eyes. You can have a motor aura, where you feel weakness or numbness in one part of the body. Previously, it used to be called as hemiplegic migraine. You can have autonomic features like perspiration, dizziness, strange noises coming into your ear sometimes, or simply you don't feel that people who are talking around you, it doesn't seem like feels good on your senses. We call it photophobia. And sometimes it could be language aura as well, where either you are talking gibberish, or simply you want to say something but your words are not making sense, or it's very difficult for you to articulate the words. So any type of aura can be associated with this migraine with aura. And somebody who is not fitting into this criteria, let's say they do not have got a past history, this is their first or second attack, but they are either showing some symptomatology of migraine without aura or with aura, we classify them into probable migraine. And if it happens over a period of time, then they can be classified as proper migraine without aura or with aura. Now, coming down to the treatment, again, painkillers. First line of treatment is painkillers. Paracetamol, ibuprofen. Never, ever narcotic analgesics. Remember, narcotic analgesics are never the answer. Paracetamol, 10 to 15 milligram per kg per dose. If you are giving rectally, that can be 20 milligram per kg. Ibuprofen, 8 to 10 milligram per kg per dose. So you have to give it for 24 to 48 hours early, as soon as the headache starts. If it is not working, then you move on to the second line treatment. Second line treatment, again, usually if the treatment, usually if the headache is very severe, you have to admit them, and you can give them an IV saline bolus, 20 mils per kg, and in that you can add what we call as a cocktail treatment. So you can add prochlorperazine, Stamitil into that, or you can add metoclopramide with diphenhydramine, just to counter the side effects of metoclopramide, or you can just give parenteral ketorolac as a painkiller as well. So this usually aborts the migraine cycle. If you have to use the triptans, sumatriptan or zolmitriptan, they have to be given early in the course of migraine, because once the severe headache starts, it's very difficult to break the cycle just with these triptans. The other thing about triptans is that the nasal administration or the subcutaneous administration of triptans is far better than the oral one. Again, this has been time tested and research has proven this thing. Prophylactic medications are important if somebody is having frequent attacks of migraine. Usually we use propranolol. It's a very safe drug, can be given in low doses. There are some other drugs like low dose of anti-epileptic medications, valproic acid or topiramate can also be used in those where the propranolol is not working. Some antihistamines are also used, but again, their effects, it's not that much effective. Nevertheless, if the second line medications are not working, then they need to be referred to the specialty so they can be worked up. But normally, in very simple migraines, you do not need any investigation. Investigation is only needed if there are some associated symptoms which are pointing in some other direction, like a febrile illness or neurological signs and symptomatology, which might be pointing towards some intracranial pathology. So only then they would require some form of workup. But for plain migraines, they don't run out. It's a clinical diagnosis. And usually with first line or second line treatment, usually these treatments are quite effective. So this was in a nutshell the pediatric migraines. If you've got any question or query related to this particular topic, as I said earlier, you can put down your questions in the comment section below and I will get back to you as soon as possible. Again, if you have liked my videos, subscribe would be fantastic and it really helps, and you can share this video with your friends. Have a good day. Bye-bye.